In a microcytic picture, the dominant problem is impaired hemoglobin synthesis. Because hemoglobin is built from heme, which requires iron, plus globin chains. Anything that disrupts iron availability, heme synthesis, or globin production produces small red cells. The first test to order is serum ferritin, which is the storage form of iron and the single most useful surrogate for total body iron stores. A low ferritin is essentially diagnostic of iron deficiency anemia, the most common cause of microcytic anemia worldwide. Common causes include chronic blood loss from menstrual bleeding or occult gastrointestinal bleeding due to peptic ulcer disease or colorectal malignancy, inadequate dietary intake, malabsorption from celiac disease, post-gastrectomy states, or Helicobacter pylori infection, and increased physiological demand during pregnancy, infancy, or adolescent growth. Ferritin is highly specific for iron deficiency when it is low. A value below approximately 15 to 30 nanograms per milliliter essentially confirms the diagnosis. However, ferritin is also an acute phase reactant, so it can be falsely normal or even elevated in the setting of inflammation, masking concurrent iron deficiency. If ferritin is not low, the differential for microcytic anemia broadens. Anemia of chronic disease, also called anemia of inflammation, occurs when chronic inflammatory cytokines, particularly interleukin-6, drive hepcidin production by the liver. Hepcidin then internalizes and degrades ferroportin on enterocytes and macrophages, trapping iron inside cells and starving the marrow of usable iron despite adequate stores. So ferritin is normal or high, but iron utilization is impaired. The next consideration is thalassemia, an inherited disorder of globin chain synthesis affecting either alpha or beta chains, confirmed with hemoglobin electrophoresis. Classic clues include disproportionately microcytic indices for the degree of anemia and an elevated red cell count. Sideroblastic anemia results from defective heme synthesis within the mitochondria of erythroid precursors, producing the pathognomonic ring sideroblasts on a Prussian blue-stained marrow specimen. It can be hereditary, such as the X-linked form caused by ALS2 mutations, or acquired through myelodysplastic syndrome, alcohol, isoniazid, lead, or copper deficiency. Finally, lead poisoning inhibits multiple enzymes in the heme synthesis pathway, notably ALA dehydratase and ferrochelatase, and classically produces basophilic stippling on the peripheral smear, often alongside neurocognitive symptoms in children and abdominal pain in adults.